Of Deuk Spine Institute here in Melbourne, Florida, just outside of Orlando. And today we're going to be performing the Deuk laser disc repair surgery for 2 herniated discs on our patient who has back and left leg pain. And we're going to get started. I'm going to start by talking to my patient, so if you have questions, feel free to type them up. This is a live stream surgery. Okay, Dr. Deuk here, are you comfortable? We're going to get started, okay? You're going to feel my hand touching your back, that's normal. And then I'm going to put some medicine so that'll numb up your skin. And then we're going to get started. I'm going to be able to put you to sleep in about 10 to 15 minutes, okay? I need you awake for the very beginning to help me. Now, if you feel pain, I want you to say, ouch. Just say, ouch. And that's, if you feel a little bit of pain, you don't have to say ouch. But if you feel more than you should, you just say, ouch, okay? And tell me if the pain's in your back or your leg. So you say, ouch back or ouch leg. All right. We're going to get started, okay? So once again, we're doing the left L45, L5S1. Now it's just my hand feeling around, okay? Feeling for the iliac crest. You're going to feel me pinch your skin just a little bit, and you're going to feel a little stick and burn, okay? That's normal. I apologize. I wish there was a better way to do this. All right. Just bear with me. So we're injecting a little bit of local under the skin to help numb up the skin, to make it a little bit more comfortable for her. And through this area, we are going to pass a needle. And you might think to yourself, well, if you're numbing it up with a needle, why do you need to numb it up if you're just going to put a needle in? Well, the reason is sometimes we have to change our position, our entry point, a few times. All right, are you comfortable? All right, we're going to get started, okay? Let me know if it's uncomfortable for you. I'm going to be talking to the team while we're doing this, okay? All right, let's go with a lateral view. I think we need to come down a little bit. You have more local? All right, you're doing fantastic. We're just taking some pictures, okay? Now to navigate for this surgery, we use X-ray pictures. And the X-ray pictures allow us to see the spine and all the bones in the spine. Local? Yep. Yeah. I'll go through the area that I already numbed up and just aim a little bit south. Are you comfortable? Okay, so we've injected about 10 cc's total. Remember to let me know if you feel discomfort. Just pressure. So I'm aiming for the bottom disc, L5S1. I'm going to start there. Jordan, you've done a good job. You've lined up that pedicle nicely, I think. And yeah. Blood pressure up a little bit. There's our first drop. You're doing great. Shot. All right, thank you for letting me know. Let's have a little numbing medicine. Shot. So the first order of business today would be to access that L5-S1 disc space, and that's what we're trying to do. Shot? Give me an AP, please. Let's see where we are. Normally I like to dock off the facet and then go around lateral and anterior. You comfortable? Patient needs to be awake for the beginning. And the reason is, let's go back to a lateral. Thank you. The reason is that I need her help, the patient's help, to let me know if I'm getting a little too close to any nerve roots. They'll tell me they have pain down their leg. And then I have to stop what I'm doing and I have to redirect and avoid those nerves. So we don't want to get too close to any of the nerve roots. I've never had a radiculopathy after surgery. I have had one patient in all the years I've done this with sort of an irritated nerve. All right, that's good. We call it a radiculitis. Inflammation of the nerve root. Shot? I feel like I'm a little lower than I want to be. So I'm going to try to redirect a little bit. Shot? That looks a little better. Shot. Shot. Give me an AP. You feel anything? I need you to tell me. So far, so good? Okay, good. All right. You're doing fantastic, by the way. All right. Let's go back to a lateral view. You can see the tip of the needle is in the foramen. And we're pretty much right at the disc. It's very easy to be too lateral on these. You don't want to be too lateral. All right, that's looking pretty good. Shot. All right, so I believe that's L5-S1, and we're in a nice position. We've got one down, okay? One more to go. So at this point, I'm going to make my incision, which we've already numbed the skin up. Okay. And then I will place the next one at L4-5. So this is a 7mm incision. That's all we need to do the entire surgery with 2 disc herniations. There is no other surgery in the world other than this endoscopic technique that allows you to make such a small incision. Now, if this patient had open surgery, which is what most spine surgeons in the world do, there would be a very big incision, and she would have a lot of pain afterwards, which she's not going to have because she chose the endoscopic surgery. Much better surgery. And I'm going to show you what I'm talking about in just a moment. I just want to finish placing this. Now when we're done, we're going to put you to sleep, okay? And when you wake up, you'll be finished with your surgery. Shot. And then you'll get to watch it on video. Shot.
We have a question whenever you're ready.
Sure.
One of our viewers is wondering, Doctor, when I stretch and try to decompress my spine, I get a grinding feeling in my lower back near L4-5. The pain usually gets worse as a result. Is this bone on bone, or is it my joints making that grinding and popping feeling?
Yeah, great question. So the grinding and the popping people get in their spine, either in the neck or lower back, that's your facet joints. Look it up online, F-A-C-E-T. Actually, better than looking it up online, go to the Deuk Spine app and download it for free. Or go to our website. But that's called Facet, F-A-C-E-T syndrome. Give me an AP. And basically, if you look right now on the x-ray that we just took, you see the tip of the second needle, the higher one, is right at a white line. That is the facet joint. That is the joint that you're talking about grinding and popping. Now, generally, we don't do anything to treat that because unless you're having pain, okay? So if you're having pain from the grinding and popping, then it needs treatment. But if you just have grinding and popping by itself, we don't treat that, okay? I just want to be clear. Go back to a lateral, please. So the noise is coming from kind of arthritis in the facet joints, where there's, we call it crepitus. Crepitus is a noise that's made from an arthritic joint that's moving, and that's what you're hearing and feeling is the crepitus. But like I said, there's no needed treatment for that unless it's painful. And so a lot of people do have pain related to that, which in your case you may very well have pain. Shot? And if that's the case, that's totally fixable. We do that here at Deuk Spine Institute. So if you can, I would recommend you get your MRI in. That's absolutely perfect positioning right there. We're right at the back of the disc at 4.5. All right. So I hope I answered the question for you. But it's fixable, and Deuk Spine Institute treats that. So if you can upload your MRI or make it out here, we'll be happy to treat it for you. Now, the grinding and popping you may still have after treatment. However, the pain should go away. Grinding and popping can be treated as well. Sometimes we use PRP and stem cells. And then if all that fails, because in some patients it's not going to work, the next step after that would be potentially to do laser surgery or a fusion. So there are a lot of options. In the end, you shouldn't have any pain, though. We should be able to get rid of that pain with the treatment. The question is, which treatment will work for you? Most patients, the rhizotomy works, probably about 70%. Are you comfortable? All right, so at this point, we're going to put you to sleep in just a few minutes, but I need your help for one last thing. I'm going to show, Sean, I'm going to show the audience, if she were having open back surgery anywhere else, the incision would be much bigger. It would be something like this, okay, just to give you an idea, from there to there, okay. Now the discs that we're fixing are the L5S1 disc, which is right about here, and the L45 disc, which is right about here. I'm just giving a surface projection. Of course, this is her back. This is the L5S1, and this is the L45. Now, she has damage to both of these discs. She has a tear in the capsule, the Annulus Fibrosis, on both of these discs, and it's allowed the jelly in the center to come out and squeeze out. We call that a bulging disc or herniated disc. It's the same thing. A bulging disc is a herniated disc, okay? All right, you're comfortable now? All right, she just jumped up. Did you feel something there? How bad is that on a scale of 1 to 10? An 8, that's the highest it went, was an 8? An 8 or any higher? A 9. All right, was that where you typically get your pain? In your lower back there? Is that your typical area of the pain? All right, so that was a 9 out of 10. You all see that? That was a 9. Thank you, Luis. All right, I just wanted to test the disc. That was the bottom disc. I wanted to make sure that it is the source of your pain, and I have great news. It is the source of your pain. So that means when you wake up from this surgery, that pain will be gone forever, unless you re-injure your disc, of course, which you're not going to do. You're going to avoid bending and lifting too early. You're going to let the disc heal. So the pain she has now in her back that she gets every day comes from these two discs, I believe, based on her localization of the pain on exam, where I saw her in clinic and she pointed to this area, plus On MRI, I see 2 herniated discs, 4551, that in my opinion are the cause of her pain based on the way they look and where they're related to topographically where her pain is. So my presumption going into surgery today is that these 2 discs are causing 99% of her pain, if not 100%, which I think is probably closer to 100. But I just confirmed that with the bottom disc. It's 9 out of 10 pain, and it's her typical pain. How bad is that on a scale of 1 to 10? A 9? All right, sorry about that. Is that where you typically get back pain? I got great news for you. We're going to put you to sleep. When you wake up, those pains will be gone forever, and you're going to be a very happy lady. Okay, go ahead and count from 1 to 100 out loud for me. Can you do that? Nice and loud. If you make it to 100, we don't pay the anesthesiologist today. So count fast for me. I'm kidding. All right. You're doing great. Everything is going perfect. Shot. So folks, for those of you that noticed, maybe the picture wasn't as good as it could have been, but when I injected the dye, she arched her back up because she suddenly felt pain. Now, I didn't tell her I was injecting dye. So what this test is, it's called a provocative discogram or evocative discogram. 2 different words, they mean the same thing. But the test confirmed with me that this patient discs at L45 and L5S1 are definitely causing her back pain. And so now with the Deuk laser disc repair, the only surgery in the world that actually cures back pain from a herniated disc, besides a fusion, this, and it's just not any fusion, by the way, it has to be done a certain way to cure the back pain. But forget about fusion. You don't want a big incision with screws and rods. This is the way to go. 7mm Band-Aid incision, outpatient surgery. Takes 45 minutes to do, as opposed to a fusion, which takes hours and takes months to fully recover from a fusion. Sean, all right, I'm looking to see the guide wires in place. It is at L5S1. I start with L5S1, and I'm going to remove the needle that I use to place the guide wire. Of note, she does have short pedicles at L5 in particular, less so at L4, but definitely at L5 and probably S1. And those short pedicles are something we commonly see in people who need back surgery. So, as a matter of fact, I don't think I've ever seen someone who needs back surgery that doesn't have short pedicles. So there's probably something here. I'm probably the first to report this, that congenitally short pedicles and back surgery is a very, very high risk factor for developing chronic back pain and, you know, symptomatic disc herniations. You know, disc herniations are pretty common, but a lot of people have them and they don't cause pain. All right, so I'm right here at the annular tear at L5S1, and she's responding a little bit. So it's okay with me, but I'm mentioning that only because this is the painful part of the disc. And you can see as the dilator goes into the disc that it's causing some discomfort for, please. Shot. All right. So we're inside the disc, and the movements you're seeing are not necessarily she's feeling pain, but it's her body's response reflexively at the level of the spinal cord. So there's no conscious perception of pain. It's all subconscious, meaning she's not aware of any pain. So she's not suffering like we would think people suffer, but she's having a reflex movement responding to the tube and the endoscope being there at her disc. That's painful. And this is why people are asleep for the surgery, Shot. They're asleep because you can't do the surgery with the patient awake. It would be too uncomfortable. So we do have to put patients asleep. Shot. For this part of the surgery. Now the sleep that she's under is called Twilight Anesthesia. And there's no tube down her throat. She's breathing on her own, but she's asleep. So it's IV sedation that she's getting. It is tight. Shot. Yeah. So
What do you need, sir?
let me have another wet Raytech. So we have a little bit of tissue located between the outer tube and the dilator that's kind of holding them together. All right. So I'm having to use some tricks to try to rectify the situation. There aren't a lot of tricks that I have up my sleeve, but this is certainly one of them. And that's to put the fluid adapter on. I don't know that this is going to work, but we need to give it a try. No, it does not want to separate. There must be a little bit of tissue stuck between the tube and the dilator. Yeah, we could try the vice grip. I don't want to crush the tube either. That's the problem. Or not the tube, but the dilator. The dilator has hollow channels in it. And those hollow channels can be crushed. Unfortunately. It's not moving, is it? No. So that's why we do live streams, so you can kind of see how we deal with problems in the operating room that occur like this. Okay. Let's see the guide wire. This is going to be tough. I may have to start over at 5-1. Shot. Shot. So I'm backing out the dilator and the tube because they're stuck. We call it cold welding, where they're basically quote-unquote welded together, but not really. It's just some tissue jammed in there. And shot. Yeah. And shot. Do you see the guide wire? Where? Something dropped. Shot. Shot. No, it's there. It's there, right? Isn't that it at the front of the disc? Yeah. So I'm gonna need to put some pressure. Hold this here. All right. Take that and let me see it. You put pressure here. About that much. So there it is. You all see this? A little piece of tissue in there. Okay.
Yes,
So-
I think we saw it.
What's that?
I think we were able to see it.
Yeah, there was a tiny bit of tissue in there. And wow, that's tight. Incredible. All right. Well, we're going to work on that. Meanwhile, we're going to place another dilator. Relax here. Shot. That's it right there. Shot. All right. Well, that was good. That went pretty easy. Take the guide wire out. Take this. All right. So, unfortunately, yeah, those two got stuck together. Just a little bit of tissue got in there, Shot, and that's all it took, you know, to what's called cold weld those two pieces, surgical instruments together. And of course I've had this similar situation happen before. Not quite that bad, but it's not common. Shot. All right, I'm going to pull this dilator back. Shot. All right, no cold welding this time. I think we're good. Shot. All right, take the fluoro out. So that's why we live stream, so you can see everything that happens, you know. That's not normal to happen. It's a problem, but we dealt with it. And that's how you deal with it. I don't think there's another way that's more effective at dealing with it than what we just did. But you saw the steps that I took to rectify the problem and fix it and get on with it. Okay? So, we're ready to go at 5-1. We're going to bring our scope in. Do you want to just take a quick look at the endoscopic rig? Sean?
We can see it.
All right. So here's the endoscope, rod lens endoscope. This is the irrigation. This is the light source. This transmits light to the end of the scope so I can see what I'm doing. Here's the camera, which captures an image off of the rod lens system and allows me to, okay guys, we got to be careful here. It allows me to actually see what I'm doing and project that image onto the TV screen so you guys can see it as well. So you are watching exactly what I'm watching. Our goal here is to give you the same view the surgeon has so you guys can all see what the surgeon sees. You know, when it comes to teaching new surgeons, neurosurgeons for example, we're trained in something called residency. Residency is usually for neurosurgery 7 years of training after medical school, so it's a very long time. And what every neurosurgery resident wants is to be able to get in the operating room and do surgery in the operating room, okay? And so once you get in the operating room, it's actually very hard to see what you're doing because you're standing there looking over the shoulder of a surgeon and the surgeon's assistant, if it's another resident, for example, or another surgeon. So it makes the education of residents very difficult to do. However, by doing endoscopic surgery like we're doing, by having the audiovisual system we have in place, we're able to broadcast the same view the surgeon has so that many people can see what the surgeon sees. And that's one of the unique features of our educational system we have set up here at Deuk Spine Institute, to be able to train not just the public, but also physicians that are interested in learning how to do this type of surgery. All right, so let me have the laser. The patient is snoozing away. She's very comfortable. And we're getting started with the laser. And this is the L5-S1 disc herniation. You can see there's a significant amount of basically damage to this disc. It's chronic damage. It's been here probably for some time. Definitely not days, more in the order of years. And I can tell that based on the characteristics of the tissue, the way it looks to me, plus the way it responds to the laser. Why is the arm board hitting me in the groin? Do we make the arm board as north as possible, guys and gals? Or, I mean, I know that she has a very steep L5-S1. Now, I don't want her arm past the 90 degrees at the elbow, but the bottom of the arm board towards the feet should be as far north as you guys can do it without compromising her position of her arm. Dr. Pettit, is her arm okay? Yeah, that's much better. Don't forget about that. Every case, that's why we do things the same way every time. The arm board is always as far north as possible. Okay? Guys?
Yes, sir. Yes,
On the surgeon side especially.
yes, sir.
So this is that damaged disc at L5-S1. This one was a 9 out of 10. Pain. Okay, 9 out of 10. And the blue dye is the blue dye that I injected during the discogram. And the blue dye helps me find the degenerated nucleus pulposus, which is part of the disease process, disc degeneration. You're going to get degeneration or breakdown over time of physical characteristics of the tissue. That includes drying out, standby laser, or dehydration or desiccation. It's all the same word. Drying out, desiccation, dehydration. So drying out of tissues. You get a scarring of the tissues from chronic inflammation. And you get kind of this clumpiness. The tissue loses its elasticity, its elastic properties. Most of the nuclear elastic properties come from the proteoglycans that are located within the nucleus. And these are complex sugars that proteoglycan derives its name from protein, and glycan is basically a carbohydrate or polysaccharide chain. So unlike fatty acids, they're different. They're more hydrophilic. And the disc is, hydrophilic means water-loving, for those of you who are not chemists. Philia is love. Phobia is hate. And hydrophilia means the love of hydro, which is water. Hydro is water. So hydrophilia means the love of water. So basically, the nucleus, which is in the center of the disc, is made up of very long proteoglycan chains that are very hydrophilic or hygroscopic, and they basically hold water, you know, like a watery cushion. That's what the nucleus is, a watery cushion for the body, for the discs, between the bones in the spine. So, sorry, I'll take the question in a moment. This watery cushion, or the nucleus pulposus, is in the center of the disc, okay? And like anything that's very watery, it's oozy. It can ooze around and leave the disc. So how do you keep this watery proteoglycan mixture in the center of the disc? The answer is simple. There's something called the Annulus Fibrosis. It's like a wall, okay? It's a containment wall, and it's not watery and cushiony. It's tough and strong. It's one of the most tough, elastic tissues in the body that's still pliable and compliant. And it has to be, because your bones are moving, right? They're always moving. You know, when you're bending and twisting and lifting things. Human beings' spines were built to be flexible, but the flexibility of the spine does not come from the bones. The bones aren't flexible. They are a little bit, but not much. But what's really flexible are the joints between the bones, and there's really the cushion between the bones is the disc, and that's full of nucleus pulposus, which is the jelly that's really cushiony, and that's contained with the annulus fibrosis, okay, the tough part that runs around the outside of the wall that holds the jelly in place between the bones. So when people get a tear in the annulus fibrosis, it allows the jelly inside to leak out through the tear, and that's the source of the back pain, neck pain, thoracic pain. And then if it gets that tear and the leaking nucleus material in the tear, called interposed nuclear material, if that creates inflammation. It creates inflammation because your body sees that nuclear material and says, oh my gosh, this shouldn't be here, let's get rid of it. So it mounts an inflammatory response against the nucleus pulposus, which is squeezed out through the annular fibers. And then that inflammatory response is the pain that people feel from a herniated disc. Now, who discovered this? I did. Okay, and have I published it in a journal? No. Do I talk about it all the time in these surgeries? Yes. Why? Because that's my way of publishing it, okay, without having to deal with my narcissistic peers. But the reality is that this is what's going on, and when that inflammation gets out from the annulus and the annular tear and it gets onto the nerve roots, it then irritates the nerve roots, and that's why people get leg symptoms or arm symptoms. Or if it's in the thoracic spine, rib symptoms, pain radiating around their ribs, okay? So the misnomer, the misinformation, what's unfortunately the prevailing belief that is totally incorrect is that leg and arm symptoms or radicular symptoms in the ribs come from compression of the nerve roots by a herniated disc, but that's not the case 95% of the time. It's not coming from compression of the nerve root, it comes from inflammation of the nerve root, okay? And that's why most surgeons that's why they miss the diagnosis of what's really causing the patient's symptoms of back and leg pain, or neck and arm pain, or thoracic pain with rib pain. It's all the same disease, the same condition. It's identical in all three areas of the spine. It's a tear in the annulus with a bit of the jelly squeezed through the tear, sitting inside the tear, causing inflammation. And that inflammation is what causes the patient's back, neck, or thoracic pain. That's from a herniated disc, okay? And that's what this surgery is designed to treat. This is the only surgery in the world that treats that pain. And that's because nobody else knows what causes the pain, but we figured it out here. I figured it out in the last 16 years. And we have published some of our results, but every idea, every bit of knowledge that I have from treating this disease over these 26 years as being a neurosurgeon, I haven't published at all. I published it on my videos that you're watching. If you go back and watch the 1,000 videos that I've recorded of the surgeries I've done in the last 8 years, you'll see that I'm talking about these ideas kind of over and over again, discussing them, bringing them out, shedding light on them. Yes, there's a question.
So we have a couple. One of our viewers on Facebook is wondering, Dr. Deuk, do you think disc problems are more prevalent in today's society, or is there just more attention around them now?
Great question. So Dr. Deuk, do you think disc problems are more prevalent in today's society, or is there more attention to them? I truly believe that disc problems have existed in human beings ever since the, say, Industrial Revolution, so hundreds of years ago, as people became required as part of their jobs to do heavier lifting, bending, and twisting. And I believe the disc injuries are related to activities that require people to bend, lift, and twist. Okay? Now, it's a complicated question and a complicated answer. I think there's definitely a genetic component to people with disc injuries that are symptomatic. So there's something in the genes. Well, if it's in the genes, it's been there for thousands and millions of years potentially as humans evolved. So there is definitely a genetic component that's been around for a lot longer than modern civilization, okay? And that's encoded in genes of certain people. And I think someday we're going to be able to find that gene. And honestly, we could probably do it now if I got involved at a university level and I worked with a geneticist. We could look at the chromosomes and genes of people that need surgery for their backs, that have chronic back pain from herniated disc, and we could discover the gene. I'm fairly certain of that, okay? But I'm not in a university, and I'm not working with a geneticist. So if that were to happen, I think we could find the gene that predisposes people to symptomatic disc herniations, because I truly believe there's a gene, a genetic component. Now, on top of the genetic component, I think there's also an environmental component, which means that you just can't have, faulty genes that predispose you to having symptomatic disc herniations in your spine. I think there's also has to be something happening like traumatic to your disc. All right, so why does it seem like it's more prevalent lately? So the genetic side of it is the same. It hasn't changed, okay? So what's changed, I believe, is not even the incidence of symptomatic disc herniations. I think the incidence has probably remained stable over the last couple hundred years since the Industrial Revolution, and the demands on the human body have changed, okay, from farming, hunting, gathering, to heavy labor, okay? So I don't think that there's been a change in the genetic side. I don't think there's been a change in the incidence. What I believe has changed is the ability to diagnose those herniations and treat them. So basically, modern medicine has now caught up with being able to diagnose and treat symptomatic disc herniations. And I'm going to tell you something. If you're here watching this surgery, you're part of a small circle of people in the world, okay? A small circle of people in the world that I'm bringing your understanding of this disease of herniated disc and back pain, I'm bringing it to the most contemporary level of understanding available in the world. There's nobody that understands it better than we do at Deuk Spine, better than I do, to be honest with you. And most doctors' understanding of symptomatic disc herniations and what causes the pain and how it should be treated is so far, beyond in the past, like behind us, that it's going to take them years and years and years to catch up, okay? Unless we have a societal epiphany, kind of like COVID, right? Remember when COVID hit, it took a few months for the world to really understand what was going on? And that took every media channel available in the world. It took presidents of nations. And it took, a massive distribution of information and knowledge campaign to really make the world aware of COVID and what needed to be done to treat it. So the same thing, if it happened with back pain overnight like this, it would take several months, but we could bring the world up to speed on what causes chronic back pain. It's these herniated discs. Specifically, it's the annular tear that I'm treating right here, right now, with this laser. And if we could do that, then we can eliminate back pain in the world and neck pain, literally eliminate it. And it will be a thing of the past. Now, of course, there are going to be people who are born and they injure their back and neck, right? And they're going to need treatment. So it's not like It's not like it's going to go away, like we've inoculated everyone and we've given them a vaccine and they're never going to get back or neck pain again. But the people that have it can be cured. And that's really the biggest message that needs to get out. If you have it, you don't have to live with it. Most of the patients I treat have lived with their pain. I don't have an exact number, but it's somewhere around 10 years on average. There are people that live with it for 20 years because they don't know it can be cured. They've never talked to a doctor that told them, yes, your pain can be cured, diagnosed and cured. Because we haven't had the ability to do it until more recently with this surgery. It's laser off. Yeah, I'll take the question.
So our next question comes from another viewer on Facebook who's wondering, when you see a thin line on the posterior of the disc on MRI without a bright signal, do you still suspect interposed disc herniation?
No, I'm so sorry, Sean. I could not hear what you said. I think we need just a little bit more volume, maybe 10% increase on your volume. That's herniation, by the way, right there, the blue thing. But go ahead.
Does this sound any better?
Yeah, go ahead and ask the question.
Okay. The question was, when you see a thin line on the posterior of the disc on MRI without a bright signal, do you still suspect interposed disc herniation?
Oh, okay. So this person is asking about interposed disc herniation. All right, so how do you diagnose it? And what about not having a thin, white line in the back of the disc? Can you, if somebody doesn't have that, can they still have an interposed disc herniation? So just step back for a moment and let's talk about the diagnosis of disc herniation. So the person who's asking this question is asking about an MRI. And an MRI, for those of you who don't know what an MRI is, it is a magnetic resonance imaging. It's a machine that you lay in or stand in, and it literally can take pictures inside your body. And those pictures can show us all kinds of things. But in spine world, we use MRIs of the spine to look for things that are going wrong in the spine itself. And one of those things is a disc problem, specifically a herniated disc, okay? And, thank you. There is another way to diagnose disc herniation besides MRI. You can use something called a CAT scan, but it's not nearly as good. It's much worse. But there are people who cannot have an MRI because they have a pacemaker or they have shrapnel, like pieces of metal from war or something in their body, or they have aneurysm clips, for example, that are freshly placed. So they can't have the MRI. So they get a CAT scan. CAT scan is nowhere near as good. But there is something called a discogram, which is what I did here today, where I inject dye into the disc. And then the patient can go and get a CAT scan afterwards. And the CAT scan will show a tear in the annulus or in the disc. So the question is, on an MRI scan, if you're using the MRI to diagnose the source of pain, could it be coming from an annular tear that on MRI isn't white? And what they're referring to, folks, is something called a high intensity zone. I believe that's what they're referring to with the question. A high intensity zone is an area in the disc that is under inflammation, okay? And it has inflammation going on, and that's why it's white on an MRI. Standby laser. It's white because water on T2 weighted images on an MRI is white. And that's what they're referring to. So they're referring to usually a T2 weighted image. Guys, why is their disc still in the grabber? There's a piece of herniation there. I've got to clean that out, okay? What was I saying? So the T2 weighted image of the MRI is the most sensitive MRI sequence, and there's different sequences, okay? Hey, dude. So you can't bend the laser cable that tightly. If you bend the fiber tightly, you'll crack the glass, okay? And then the laser won't come out. It'll literally melt through the side of the fiber. So don't do that. It's big loops only. Okay, so an annular tear, many times, I can see them on an MRI. And I start with the T2 sagittal images, and then, which is the long view, top to bottom. And I can see that there's a change in the characteristic of the disc. Usually it's darker, which indicates there's an injury that occurred. Okay? And then there's also a herniation. You could see it on the sagittal images. The sagittal image is really good for looking at that. On the T2 sagittal, not the T1. I don't even look at T1 images, personally. I haven't looked at a T1 spine image in years, in like literally probably 15 years. The T1, there's no other sequence but a T2 weighted MRI that is the most perfect sequence for looking for disc injuries, the kind that cause pain. So a T2 sagittal and a T2 axial. That's all I use, those two sequences, okay? And on an axial view, I'm looking for the back of the disc. The disc normally looks like a kidney bean, okay? The back of the disc, yeah, thanks. The back of the disc is normally concave. So if you're the nerve roots or the thecal sac and you're looking forward at the disc, it's concave. All right, it hugs the contour of the vertebral body. When you see the disc in the back is no longer concave, but it's flat, straight across like a line, or it's bulging, you have an annular tear with a interposed disc material, period. There is no such thing as an annular tear without interposed disc material. I've never seen it. Every annular tear that I've seen has nuclear material stuck and wedged inside it. Okay? Now, the question is, was the annulus able to heal itself into a painless, asymptomatic state or not? And that's really the gist of what goes on here. Every human being alive over the age of 40 has an annular tear and a herniated disc. Everyone. Everybody over the age of 40 has an interposed nucleus pulposus within the annular tear in the back of their disc. However, only about 5% have chronic back pain. So the reason I believe that that's the case, and this is unpublished and unproven, from a scientific method standpoint, but in my mind it's proven because I see it every single time, is that 5% of the population with herniated disc, they cannot wall off the nucleus pulposus with a capsule of scar tissue around it to basically keep it from eliciting an inflammatory response. So basically, if you understand inflammation can only occur where there is a blood supply. And that blood supply is in the form of capillaries. So the annulus fibrosis outer half has capillaries. The inner half does not. The nucleus pulposus inside of the disc does not have capillaries. They don't have a blood supply. So the only way to create inflammation is when the nucleus pulposus, which is highly inflammatory, pro-inflammatory, means it causes inflammation, when that nuclear material hits the outer wall or the outer half of the annulus, where there's a blood supply in capillaries, and then it elicits an inflammatory response. Standby laser. Okay? So that's how you get pain and inflammation in the back of the disc from an annular tear caused by interposed nuclear material. When the interposed nuclear material is in the outer half of the annular tear. What was that? Something just moved by the patient's head. Patient's okay? Can you just double check? I don't think it was her moving. I think it was like the IV or something, but... Huh? Okay, all right. All right, we're just about done at L5S1. And then we're going to go to L45 next.
We have another question.
Yeah.
A viewer on Facebook is wondering, what causes facet arthropathy, spinal stenosis, and thickening of the ligamentum flavum?
That's like an hour-long discussion. But I'll try to summarize it. So what causes facet arthropathy, thickening of the ligamentum flavum, and spinal stenosis, right?
Yes.
Woo. All right. So let's start with let me just get into a discussion here. I believe it all starts with a disc injury. So somebody bends, lifts, twists in such a way that it tears the annulus fibrosis of a disc. The nuclear material squeezes out a little bit and starts an inflammatory cascade. The disc starts to collapse. As the disc collapses, the facet joints must also collapse because they're tied together, basically. If the disc is collapsing, that means the vertebrae above is collapsing down, translating or moving down towards the vertebrae below. Okay? So the moment you injure your disc, it starts to collapse like a tire in a car. It starts to deflate. Okay? And as the tire deflates, the chassis, the bottom of your car, moves towards the road. Period. Because you can't deflate a tire without the car coming down towards the road, because the car has weight. It's heavy, and it wants to sit on the road. The only thing keeping it from sitting on the road is the inflated tire, okay? So think about the two bones that way, and basically, once the disc starts collapsing, it's like your tire collapsing. You understand? Grabber. And so the bones start to sink towards each other, the top bone sinking down to the bottom. As that happens, the facet joints must collapse also. And so they do. And as the facet joints collapse, they sublux. And that's what chiropractors treat, sublux facet joints that are painful. So this process of subluxation or slippage, collapsing of the facet joints onto each other, creates the body responds, because it's called instability, and the body responds to that instability by thickening the facet joints, causing over time the facet joints to get larger. We're pretty much done here. Okay, we're done. And as the facet joints gets larger, it's called hypertrophy, facet joint hypertrophy. Scope off. Scope off. As the facet joints hypertrophy and get bigger, they cause stenosis. Okay, let me have it. So they cause narrowing of the hole where the nerves come out. Take. Okay, so facet joints get bigger as a result of what's called instability, okay, or stress. Stress causes the bone to respond and remodel. The facet joints are made out of bone. There's an inferior facet and a superior facet. They're bone. They come off the vertebral body. And as they start to experience stress, which is abnormal movement from the facet joint subluxing as a result of the disc collapsing, that causes stress on the bone at the facet joints. And that causes them to enlarge. That contributes to spinal stenosis, because the hole where the nerves come out is literally just in front of the facet joint. So as the facet joints get bigger, they cause stenosis, but they don't cause central stenosis so much. They cause narrowing of the lateral recess and the neuroforamen. And those are the areas where nerves really get pinched, and they cause leg symptoms, for example, neurogenic claudication. So it's the narrowing of the lateral recess and the neuroforamen, which is just medial and anterior to the facet joints. That facet joint hypertrophy contributes to the greatest amount of stenosis. Not yet. Okay? Then why do the ligamentum flavum thicken? The ligamentum flavum stabilizes the segment as well in the back by the lamina, and it goes out into the facet and foramen, attaches to the facet. So the ligamentum flavum is a ligament. The ligament gets thicker over time due to a combination of inflammation within the ligament, but also in response to abnormal movement of that segment. Those two bones are moving abnormally, so it's pulling on the ligament, stretching the ligament. So the ligament's response is to get thicker. We need a lateral, right? Why are you in the AP configuration? Am I missing something? You just listening to me talk? All right, so the ligamentum flavum gets thicker because it's under stress. And the stress comes from abnormal movement of that segment. The abnormal movement of the segment comes from the disc collapsing and the bones coming closer together to each other. Kind of like a car gets closer to the road when your tire's flat. You can actually scrape on speed bumps, right? Whereas normally you wouldn't. So it all begins with disc pathology, with the annular tear, then the degeneration of the disc that ensues. And that has an effect on the facet joints, the ligamentum flavum, and even the nerve roots. Everything in that area of the foramen and the lateral recess. So that's what causes facet joint hypertrophy, is instability and abnormal stress as a result of the instability. Yeah, she's responding a little bit too much. And then shot, and then the ligamentum flavum, again due to stress, increased stress in that on the ligament causes it to thicken. By the way, I mean, we've talked about this before, but any tissue in your body, virtually any tissue except for your brain, will actually hypertrophy as it's stressed more. So whether it's bone, whether it's your liver, whether it's your skin, if you rub your skin and chafe your skin every day, it gets thicker. I don't know if you know that, but it gets thicker. If you work out with weights every day in the gym, your muscles get thicker, and your bones also get thicker and stronger. As a matter of fact, the only way to prevent osteoporosis that we know of is weightlifting when you're in your teens and early 20s, because it causes the bones to hypertrophy and get thicker and stronger, so that by the time you get to be a bit older, you already have extra thick bones, so they still deteriorate, but they deteriorate slower. I mean, they deteriorate, but you started out with more. She's responding a little too much. So I've addressed the facet joint enlargement, facet bone enlargement, facet capsule also enlarges due to stress. I've addressed the ligamentum flavum. Let me know when I can proceed. And then there was also the stenosis, which is narrowing. Stenosis just means narrowing. And the spine has holes where nerves run, and those holes get narrowed when the facets get larger, when the ligament gets thicker, when the disc collapses, and when you get herniations. You ready? All those morphological changes contribute to the narrowing. Shot? That's it? Okay, take that. Take this. Shot. Good. Shot. All right. That's at 4-5. We all agree? Yeah, thank you.
We have a follow-up question.
Sure.
This is the same viewer that asked about the last question. She's wondering, is surgery the only way to help my pain at this point?
Sean, you trail off, unfortunately, when you ask your questions. Is surgery the only way to, and then it died out.
Help my pain at this point, is what she said.
Help her pain. I see. I honestly don't know anything about your pain unless I've seen your MRI. But if you're wanting to know what can be done to help your pain, I would recommend submit your MRI shot for an MRI review. We do it for free. And then let me look at it and tell you what's causing your pain. I'll also need to do probably a Skype with you, and that way I can see where your pain's coming from. But if I could see where your pain's coming from on a Skype and I could see your MRI, I could tell you what's causing your pain. And if I can tell you what's causing your pain, I can tell you what the treatment should be. Otherwise, I'd be guessing. So there are a lot of causes of back pain that don't require surgery. And the only people that need surgery are the ones that have a surgical problem. For example, a herniated disc, or if you have sacroiliitis, for example, or sacroiliac joint dysfunction, and it fails to go away with the injections and therapy, rhizotomy and PRP stem cells, then I think surgery would be the option for you for that. If you have a coccyx pain from your tailbone, I'd recommend injections first. If those fail, then you consider getting the coccyx taken out. So there's really, to be honest with you, a lot that can be done. Wait a second, let me see where this, yeah, okay, we're good. A lot that can be done that doesn't require surgery. But the most important step, first step, is to make a diagnosis. Without a diagnosis, there is no way to fix your problem. And unfortunately, that's really, in my opinion, the biggest issue around the world in treating chronic back and neck pain, is that the doctors don't know how to make the right diagnosis. And that's something Deuk Spine Institute has perfected over the years. But it's not just, it can't be done by just one doctor usually. You need a team of doctors. And we have a team here. And you need an interventional pain management doctor who knows what they're doing. You need a therapist, physiotherapist, and a surgeon usually to complete the team. And the reason for that is there are causes of pain that are treated with, non-surgical treatment and diagnosed with injections. So if I suspect, for example, your facet joints at L3-4 and L4-5 are the cause of your back pain, then I need to do something called a medial branch block, and that's where I go in and numb up those joints that I think are causing your pain. I use Novocaine to do that, but I can't do that unless I have interventional pain management training. So you need an interventionalist, someone who can direct a numbing shot directly to those joints, kind of like the dentist will numb up the tooth that they're going to drill a cavity on so you don't feel the pain. So it takes away pain. That's what that injection does. But it takes it away from very specific structures so that it aids in the diagnosis of the source of your pain by doing selective blocks. I'm not talking about a nerve root block. I'm talking about a joint block or a muscle block to help localize where the pain's coming from. But I've been doing this long enough now, and I have enough confidence that I'm pretty darn good, probably to about 95% accuracy using the physical exam and your MRI scan. So that's why we do the free MRI review and the free Skype for anyone interested, is that I can be about 95% accurate through just those two tests if they're available. Okay, we're doing the L4-5 disc herniation, repairing it. I'm zapping away this herniated nucleus pulposus that's blue. And at the same time, I'm zapping this stuff away. This is the interposed nuclear material we talked about or somebody asked about. I'm going to say a few things because I assume there's no questions right now, but if you're watching this surgery today on the, 26th, 27th? The 27th of April, 2021, then you're probably watching a live stream. We do live stream of all of our surgeries so that it gives people that are watching the ability to ask questions and participate with the surgery, be here in the operating room basically with us without actually physically being here. But bringing your eyes and ears and and your brain into the experience with us, okay? And we do that because we want to share the experience with you. We want you, the audience that are watching the surgery, to feel like you're here. You're, able to interact with the team. If you want to ask the anesthesiologist a question, I could relay him a question. Or if you want to ask the surgeon or any member of our team, we can do that. There is a Deuk Spine Institute app for your Android phones and your iPhones. We have two apps, basically one for Android, one for iPhone. The app is a wonderful thing to do. Download it. It's free. You get lots of information in there. We have links to, videos, surgeries, testimonials. We have a library that goes through some of the common diagnoses of the spine and how to diagnose and treat those conditions. So it's a great resource for anybody that has back or neck pain or thoracic pain. We also have a Facebook support group. If you're interested, you're welcome to join. We only ask that there's no advertising being done on that support group outside of by anybody, any of the members. So it's free. It allows you to join and ask questions. And I know we've had some really good posts lately in the Facebook support group. The name of that support group is called Spine Surgery Support Group. I'm always answering questions myself as Dr. Deuk Majan or Deuk Spine. And we get a lot of really good questions there. We are also working on a Roku channel, a Deuk Spine Institute Roku channel, which we hope to launch in the next couple of months. If you Roku at home with your television, you'll be able to search for the Deuk Spine Institute channel, and we plan on having streaming 24/7, where you can actually watch surgeries. You can learn more about the treatments for chronic back and neck pain, the causes. So we're going to do some really interesting programming as well. And we have literally thousands upon thousands of hours of content that we're going to run through the Roku channel for people that have smart TVs. And for those of you that have stupid TVs, just go to our app or our website. I couldn't help it, folks. It was just right there. All right, we're wrapping up this L4-5. There's a lot of scar tissue here right where I'm at. You see the golden color? That's all calcium. That's what the laser does when the laser energy hits a piece of tissue that has calcium in it. It turns a golden color. And the calcium gets there. It's calcification. It happens when your body has some abnormal tissue. And of course, the abnormal tissue here is the degenerated disc scar tissue that's right here in this disc. That's a result of the annular tear and the herniated disc causing inflammation for probably a long time, many years. I need about 3 minutes left and I'll be done, doctor. 3 minutes. So if you have questions, feel free to type them up and ask them. I'm going to be coming over to the conference room, and I'll do a wrap-up session where I can answer questions, and I'll talk a little bit about the surgery. But this surgery went very well. Once again, she had 2 disc herniations, one at L4-5, one at L5-S1, that were causing her back pain and left leg pain. And so I expect that pain to be gone at the end of the surgery. It's probably gone already because we're almost done here. And when she wakes up, hopefully we can do a quick interview with her in the recovery area before she goes home. The surgery you're watching is an outpatient surgery, by the way. This is not being done at the hospital. This is done at Deuk Spine Institute in our surgery center. All of our surgeries are done outpatient. No hospital stay. I haven't done a hospital surgery in many years. I don't do hospital surgeries anymore. I don't believe the hospital is a safe place to do spine surgery. Every single spine surgery that I do, including the very complicated surgeries that even other spine surgeons can't do, we do them all outpatient. We do them all right here in our facility. We have the most state-of-the-art spine surgery center probably in the world. We don't have a robot. If that tells you something, I don't believe in robots. Robotic technology, in my opinion, is completely unnecessary and a waste of money. That money should be spent on things that actually help patients with their surgery and their treatment. Robot does not. We have literally the most advanced spine equipment in the world here. So we have great staff, and we have the best in terms of medications to treat patients for their conditions. So, and I don't mean drugs like narcotics. I mean steroid medications and advanced pain medications that are non-narcotic based. For example, Exparel. We do use Exparel. It is a lidocaine topical anesthetic basically that we inject inside the muscles when we do open surgeries to help patients recover faster with less use of narcotic medications. So, all right, we're just wrapping up this disc. You can see some of the fibers of the posterior ligament there, the white fibers, which seem to be fine, intact. Just about done. And this once again is the L4-5 disc herniation we're wrapping up. We already did the L5S1 earlier. That was the first one we did. And things are looking pretty good here. Let's take a peek. There's the epidural space. The nerve root, the L4 nerve root will be there. That was the annular tear. And I've debrided it. Now it can actually heal. Just want to make sure I get all the nuclear material out. Looks good to me. All right. Sean, I'm going to head over and answer questions. So, folks, type up your questions if you have any. Laser off.
Lights on, please.
You got to grab the laser fiber, man.
Then you're completely done with laser. He's on. Yeah, yeah. So, you have to unput it.
Scope off. Let's show the audience once again the incision. Sean, you want to come in and take a look here? Can you see, Sean? I don't hear you. All right, very good. So you can see this is the middle of the back here, and we had two discs that we fixed. The tube goes at an angle into the disc. We're going to remove the endoscope and tube, put a little pressure on the muscle. We've lost about 3 milliliters of blood this whole surgery. So I'm going to apply a little bit of pressure here, but you can actually see the incision is about 8 millimeters. Go ahead and put pressure. We're going to put a Band-Aid, close it up. I'm taking a Raytech off the field. All right, any questions about the surgery? She's going to go home in about 30 minutes. Again, she had propofol sedation. Propofol comes out of your system really quick, like one of the fastest anesthetic agents to disappear. Sometimes people ask me, oh, Dr. Deuk, your patient doesn't have pain, but maybe that's from the anesthetic. No, propofol is not a painkiller. Propofol doesn't take pain away. It only puts people to sleep. So when you're awake, the propofol is gone. There is no lasting pain relief effect. So when people say they don't have any pain anymore, they really don't have any pain anymore. We're not giving them any medication to take the pain away. All right, I'm going to head over there and answer questions, so type them up. surgery, and our patient had two herniated discs, and as a result of those two herniated discs in her lower back, one being at L4-5 and one being at L5-S1, she's had back pain for years, and that pain kind of goes down her left leg intermittently. And so the leg symptoms are not coming from the disc itself, they come from the nerve root. And just to give you an idea of what I'm talking about, I'm going to show you this model here. All right, that's pretty good. And where's my toothpick? Let's see. Sorry about that. For those of you who are not that familiar with the spine, this is a model of the spine of one vertebral segment, and a segment consists of bone on the top, bone on the bottom, and a cushion between the bones. Now the cushion between the bones, the vertebral bodies, is called the disc. So when you hear about a herniated disc, ruptured disc, bulging disc, extruded disc, whatever disc, this is the disc they're talking about. It's called the spinal disc, and it has really two parts to it. It's got a soft jelly in the middle, that's the red stuff, and then it's got a tough wall around the jelly that holds it in. And when you look at the disc from the outside, this is the wall right here. It's super tough. It's made out of collagen and elastin. So it's very dense, it's like if you ever have a steak, that rind around the steak is super chewy and tough. That's what this is. It's the same stuff. It's a type of fascia. Now, the jelly inside is not the same. It's full of water. It's very cushiony. And so the problem happens when the disc gets injured and you get a tear in the wall, this containment system. And that tear goes all the way through to the center. And let me show you what I'm talking about. Okay, so here's that disc. When you get a tear in the annulus, this is the annulus, it's torn, the fibers literally rip apart, and the jelly from the center squeezes between the fibers. And the fibers of the annulus, this fiber, it cannot really heal across again because that jelly is wedged in there. It keeps the fibers from healing. But the fibers don't know that. They just want to heal. And so your body creates this inflammatory process of trying to heal, trying to heal, trying to heal. And that goes on every second of the day, every minute, every hour, 24/7, 365. And it goes on for years trying to heal. And that's why people have the back pain or the neck pain or the thoracic pain. I just say back pain because I'm not going to sit here and say back, neck, thoracic every time. So when I say back pain, I mean neck and thoracic as well. It's the same pathophysiology, the same condition. So there's structurally a tear in the outer containment in the annulus fibrosis, which is the wall around the jelly. That tears, the jelly pushes out, it wedges in between the tear, and then it causes inflammation. Now that inflammation can stay inside the wall or the annulus, in which case you only get the back pain, or the inflammation can spread out and get on the nerve root. And let me show you what I'm talking about, okay? Here's, in this model, you can actually see the herniation right there, the red thing. And look at this golden thing. That is the nerve root. That goes all the way down your arm or goes all the way down your leg, okay? So when a herniation happens next to a nerve root that goes down your arm or leg, or even in the thoracic spine, this part where the ribs are, it can get on a nerve root that wraps around the ribs. So people with the thoracic disc herniation that's painful, that herniated inflammation will get on the nerve root that wraps around the rib. So they'll get pain that radiates off to the side around their rib. Thank you. Anyway, it's the irritation of the nerve root that causes the symptoms down the leg or arm, okay? So one thing that I always ask patients that I'm treating, the first thing I say is, do you have back pain? Do you have leg symptoms? Okay, because the back pain comes from something different than what causes the leg symptoms. Now, I want to clarify something. People always ask me, oh, Dr. Deuk, I need help. I've got horrible pain in my back. I need my spinal stenosis treated. And that's something we need to clear up. Spinal stenosis is narrowing of the holes where the nerves are, okay? And that narrowing or stenosis does not cause back pain. It does not cause neck pain, ever. Spinal stenosis causes leg symptoms or arm symptoms. So if the spinal stenosis is in your cervical spine, in your neck, then it's going to pinch or irritate nerves that go down your arm. So you're going to have pain down your arm, numbness and tingling in your fingers, weakness with your arm, those are all signs of a nerve problem in the neck. If it happens in your lower back, then the nerves that the herniations are going to affect are the nerves that go down your leg to your ankle, to your foot, to your toes. So when you have a herniated disc in the neck and you have, or you have spinal stenosis from the herniated disc, the symptom that the patient can have as a result of the stenosis or narrowing is the arm symptoms. Or if it happens in the lower back, the leg symptoms, okay? Spinal stenosis never causes neck pain, never causes back pain, ever. Completely different situation or condition. So what causes the neck and back pain is the inflammation in the annular tear, right here, from the interposed nuclear material. And again, this is our discovery at Deuk Spine Institute. We're the first ones to discover it and to talk about it and publish it online and in our videos. This is the source of back pain, neck pain, and thoracic pain. On the other hand, when you have leg symptoms or arm symptoms, it's because of the nerve root, not the disc itself, but the nerve root being affected. Okay, so two different problems. Now, Deuk laser disc repair surgery we just did can fix both. The Deuk laser disc repair surgery is endoscopic, and we go into the disc right where the tear is, right where the herniation is. So literally, we are pushing through the herniation as I enter the disc. Okay, so I'm moving the nerve roots over, but as I come in with this needle and then the dilator, I go into the herniation, pass through it into the middle of the disc, and then I bring the guide wire, and then I bring the dilator down. Okay, and let's just take this pin, pretend it's the dilator. So I'm coming like this, just lateral to the facet, and I'm going in the foramen, and I'm hitting that herniation, and I'm literally banging the hammer, and I'm pushing the herniation back into the disc as I advance the dilator. And then we bring the tube over that, and then we've got a tube sitting inside the herniation and annular tear, and I zap away the herniation as I pull the tube back out. That takes care of the annular tear debridement and the herniation. If you don't do the annular tear debridement, you're not going to cure the back pain or neck pain. Okay, and that's what the Deuk laser disc repair. It's the first surgery in the world to do an annular debridement. Nobody else had ever thought of it. Nobody else figured it out. We figured it out here, and that's why we do the annular debridement. The annular debridement is the most important part of the surgery. It's basically the entire surgery. As I'm debriding the annular tear, I'm also taking out pieces of herniation. So the primary objective is not herniation removal or decompression like all these other surgeries you hear about, laminectomy, microdiscectomy. They're all about decompression. This surgery is not about a decompression. This surgery is about an annular debridement. And that's the only reason why it works to get rid of back and neck pain, like no other surgery. Okay? Any questions?
Yes, we have a question. The viewer's wondering, how long does it take you to know that physical therapy and injections are going to work?
So somebody is asking, how long does it take physical therapy and injections to know that it's not going to work? I think, there's different ways to look at this, okay? If I wanted to be like 99% sure physical therapy and injections and time is not going to work to cure someone's back or neck pain, then 2 months is the magic number. 2 months. If you've done physical therapy, behavioral modifications, kind of taking it easy but still staying active, and you've done the injections, and 2 months later you're still having pain, they're not going to work. Okay, you've got something that needs a surgery like the Deuk laser disc repair to fix it. 2 weeks, I think, is also a fair number for somebody who's like me, a little bit impatient, wants to get back to their life quicker. I think the chance that the pain will go away after 2 weeks of therapy and injections is probably only 10%. So by the time you hit 2 weeks of suffering with injections and therapy and taking it easy, if you're still having that pain, there's a 90% chance it's not going to go away without something like the Deuk laser disc repair fixing it. So for those of you that are a little bit impatient and want to get it done and get fixed, then I would wait 2 weeks. Anywhere between 2 weeks and 2 months. 2 months for sure. If you're still having pain in your back or neck,
2 months after the injury, it's not going to go away on its own. You need something done. And the Deuk laser disc repair is the very best procedure in the world. Why am I promoting the Deuk laser disc repair? Because it is the best. I do all the other surgeries available in the spine. I have no limitation. We have the equipment at the surgery center to do anything. We've even taken tumors out of people's spines, okay? We can do anything here. We literally have the very best of everything. And so why do we do the Deuk laser disc repair? Because it is the best procedure of all treatments. There's nothing better. You know, fusion is not better, artificial discs are not better, laminectomy is definitely not better, microdiscectomy is definitely not better. All those surgeries I've done, many, many, many of them. I've been doing this 26 years and I've been trained to do all of them. But I can tell you right now, most of them don't work. And that's why I don't promote them, I don't recommend them, I don't do them. I make a lot more money doing fusions. I make a lot more money doing open surgeries, but I don't do what's best for me. I do what's best for the patient. So my recommendation is what I would recommend if I were the patient. If I had that herniated disc that was causing pain, I would want the endoscopic laser surgery. That's why I recommend it, because it's what I do for myself. That was apparently our only question. So, okay, great. Well, that was our only surgery for today. I hope you enjoyed it. Hopefully we'll have some more surgeries for next week. Yeah, check out the website. Also look at the Deuk Spine app and download it. It's free. And remember, we always provide free opinions for MRI review and a free Skype teleconference. So we can help you out wherever you are in the world. Even if you don't come treat with us, we'll still do our best to give our opinion about what's wrong and what needs to be done.